you see me?
I can in the corner.
All right. Well, it looks like everything is working. So, yeah, we'd both like to say hello, and I'd like to start by saying thank you for organizing this and having us. And since this is geared toward PSA screening and kind of updating our primary care physicians, I just wanted to start by saying thank you to our primary care physicians that have tuned in or that will watch on the video recording later. Here in 2020, these are trying times for physicians in our communities, and primary care doctors are some of the true healthcare heroes on the front lines. So thank you for all that you do, and thank you for being here today. And I also want to say thank you to Arkansas Prostate Cancer Foundation, and specifically Kara, for organizing this and putting together the presentation and letting us, participate. So I'd like to go ahead and just start off by talking about prostate cancer and going over the early detection guidelines. So prostate cancer, going over the biostatistics and epidemiology, is estimated to be around 191,000 new cases of prostate cancer in 2020. 33,000 patients will die of the disease, so making prostate cancer the most commonly diagnosed cancer and the second leading cause of cancer deaths in American men. During this same period, nearly 20 million men in the United States will be confronted with the important decision on deciding to undergo early detection from prostate cancer with PSA screening. And men born in the U.S. have around a 1 in 9 chance of eventually being diagnosed with prostate cancer. And depending on which studies you look at, this might even be as high as 1 in 7, seen recently. Yeah. Also, about 1 in 41 men will have a risk of dying from the disease. So, as we all know, especially in the primary care field, PSAs as a prostate cancer screening tool has gotten a bad rap in previous years. But I'd just like to point out that PSA screening is the most important cancer biomarker in the history of cancer screening and surveillance. However, and the most useful, it's just been used wrong in the past. And so that's the idea with some of these updates, is to try and use it as the important tool that it is. Importantly, to point out, from 1993 to 2016, death rates from prostate cancer in the U.S. fell 50%, largely due to early detection and improved treatment. And although death rates did stabilize in the last few years of that period, and so I know in 2020 we're all about flattening out curves, importantly so, but that's one curve we don't want to flatten. We want the death rate from prostate cancer to continue to drop. And so an important part of that is early detection through PSA screening. The NCCN, or National Comprehensive Cancer Network, panel supports the continued use of PSA testing for early detection of prostate cancer in informed, healthy individuals in certain age groups, which we'll go over. The panel bases its recommendations on level 1 evidence from randomized trials that observed a reduction in prostate cancer specific mortality in men who underwent PSA screening. Some of those trials, such as the Gothenburg trial, the European EORTC trial, and the PLCO trials, obviously have been quoted in the past. And I think the other important thing to do is to revisit those trials and see that PSA screening importance increases even more over time now that those trials are 13 years out. The importance of PSA screening is even more recognized. The panel, however, does uniformly acknowledge the risk of overdetection of otherwise indolent disease and the attendant risk of overtreatment. And as I alluded to before, that's the us as urologists, after we get patients that have been screened for prostate cancer, that's kind of where we come in as far as risk stratification and talking to patients about their options for prostate cancer, and one of the growing options being active surveillance of that prostate cancer if it is appropriate to do so. So now I'd just like to kind of do a review of the NCCN guidelines updated in 2020. So a good baseline evaluation is to start with a history and physical. This includes going over any important family history of cancers and that might be due to prostate cancer in the men in the family, as well as breast cancer in the women in the family. Also identify any other risk factors such as race and any medications that may contribute to the disease process. Also, to start the risk and benefit discussion about offering prostate cancer and early detection techniques such as a baseline PSA or a digital rectal examination. Based off these NCCN recommendations, they recommend screening at age 45 to 75 or at age 40 for higher risk individuals such as men of African American descent or those with germline BRCA mutations or perhaps increased risk due to positive family history of either breast cancer in the women or prostate cancer in the men of the family. And then at the upper level, recommending that men greater than 75 years of age only being screened in select patients. So when we talk about screening in these populations, generally what's going to happen is a man around age 45 with average risk is going to undergo PSA screening as a serum blood test as well as a digital rectal exam. And based off of those results, that can guide further PSA surveillance. So if PSA less than 1 in this early age group is has a very high sensitivity, and anything less than 1 pretty much negates any benefit of testing this patient in the next 4 years. So the recommended testing for a value less than 1 would be 2 to 4 year intervals. And, obviously we're going specifically over the NCCN guidelines, but if you look over all the different societies guidelines, such as the AUA or different specific study-based recommendation guidelines, such as those put out by UCSF and the University of California, San Francisco, this could even be done in intervals at 5 years based off these patients' risks. PSA values coming back at 1 to 3 would result in a annual or biannual testing, and then a PSA greater than 3 generally in this age group is going to warrant further investigation. Also, if this correlates with any kind of suspicious findings on a digital rectal exam, and these are the patients that would definitely benefit from referral to a urologist to discuss their risks and next step, whether that be further PSA surveillance, biopsy, or isoform testing, which we can kind of touch on later. A PSA less than 4 with a normal digital rectal exam and no other indications for biopsy, is in men greater than 75 years of age can be categorized into the algorithm based off of their risk and life expectancy, needing PSA testing kind of in the 1 to 4 year range. Anytime a PSA gets over 4 or there's a suspicious exam, then certainly these patients should be referred for evaluation and discussion with urology. Also, the question is, when do you stop screening? Screening men for prostate cancer, the general consensus is if they have a 10 to 15 year life expectancy, then this is someone that should be screened. If they have less than that and otherwise don't have an elevated PSA pre-existing or a suspicious digital rectal exam, then these are men that would probably benefit from the cessation of PSA screening in this age category, greater than 75 years of age. So in this age of testing, kind of like we just discussed, which age do we start testing? So the NCCN is going to recommend screening patients beginning at age 45 for average risk patients, earlier for high risk patients, starting around age 40. If you look at the AUA guidelines, they're going to recommend screening at age 50, or sorry, at age 55, and going till age 70. So depending on the which society you look at, there are slightly different recommendations as far as what age to begin. But I think the important thing to focus on here is we want to screen men that are young and healthy. And so, if a man in his 40s wants to undergo PSA screening, there's certainly great data to suggest that that's going to be a benefit to him. And just because he gets a PSA test doesn't mean he has to get one every year. A good baseline test for a man in his 40s can really give a lot of information. If that comes back with a value higher than 1, then this is something that he really needs to, watch closely in the future. And if it comes in at less than 1, then, there's some reassurance there that he probably doesn't need to get tested again for 5 years, and his risk is significantly lower, and he's probably in the bottom tentile of the population as far as risk for prostate cancer. For average risk men in their prime years for concern for prostate cancer, ages 55 to 70, testing in intervals at 1 to 2 years is recommended, especially if they have a PSA value greater than 1. And this is pretty sensitive. The value 1 or greater is shown to be above the 75th percentile for younger men, so men younger than 50. And median PSA values are around 0.9 for those in their 50s, ages 50 to 59. So, and then as we discussed before, stopping testing around age 75 or greater than age 70, or anytime there's no previous concerns for prostate cancer and a man has less than 10 to 15 years life expectancy. And that's pretty much policy shared between the NCCNA and the American Urological Association. So screening in high-risk populations, as we discussed before, some high-risk population patients might be those of African-American descent, men with a first-degree relative with prostate cancer, especially the cancers that were found at a younger age in their family members, and patients with a family history of breast cancer in the women in their family. This can all be, elucidated through family history, which, at the time of history and physical and discussions with our patients. And, in this day and age with DNA testing, patients might even come in with personal or familial germline mutations that have been identified in them or their family members, giving them, an elevated risk for cancer. And so these patients will be put into the high risk category. Another tool for for prostate cancer screening is prostate MRI. It's definitely not as prevalent as PSA screening, and its exact role is still kind of being identified in the research. However, it can be useful as a adjunctive test or a second line test for either a normal PSA with a concerning exam or an elevated PSA in an otherwise healthy patient. And so, MRI is becoming more and more readily available, and it's a safe exam. It does take some time. There's certain costs associated with this, but it can definitely give some data that help decide. And certainly at the time of urological evaluation, we're utilizing prostate MRI more and more. But as far as in the primary care setting for prostate cancer screening, it's hard to say exactly what role prostate MRI might have, but other than it can provide some useful information, giving any identified lesions a high-red score and helping find their risk. If you look at the studies more recently, just to touch on this, we could talk about prostate MRI all day, but if you look at the more recent studies, a knee-jerk reaction type prostate MRI, getting it every time there's any concern or elevated PSA, is going to result in probably 25% over detection of low-grade cancers. And it's going to miss about 23% of high-risk or more clinically relevant prostate cancers. So it's certainly not a perfect test, and it has some inter-facility variability. But when we're dealing with something like prostate cancer that's difficult to risk stratify, it can certainly be helpful, especially for the urologist. I kind of talked briefly about different isoforms or biomarkers that can be used, such as, along with PSA, such as 4K scores, different DNA or exosomal biomarker-based tests. I think as far as screening goes, anytime there's an elevated PSA, you could certainly obtain a 4K score. I think in more recent years, this has become more cost-effective. And a PCA3 score can certainly has a great sensitivity and can be useful. However, it does require a digital rectal exam and some patient discomfort to obtain this. And then exosomal biomarkers are kind of newer to the game, so going to be a little bit more on the costly side of things, but can help identify high-risk patients that would necessitate urology referral and likely biopsy. And the reality is, if you can get these tests based off how comfortable you are with them, and I'm happy to discuss these further on a more individual basis. It's just kind of beyond the scope of this talk, but it can be obtained at the time of elevated PSA, or it can also be obtained by the urologist after referral. So it just kind of depends on your practice and what you're comfortable with taking on. So in summary, I'd just like to reiterate, since the early 1990s, there's been many variants of the PSA assay that have been introduced in attempts to increase the sensitivity of early detection of prostate cancer while maintaining specificity and eliminating unnecessary biopsies. The NCCN guidelines recommend as a method by which individuals and their physicians can use these techniques to have a shared decision-making discussion for the early detection of prostate cancer. And these are meant to be a vehicle for providers to help, assist in early detection in a systematic fashion based off of randomized controlled trials. And so I think it's definitely an important part of men's health. And I'm happy to answer any questions anybody has, or for those that are tuning in later and watching the recording, any questions can be submitted to Kara, and she can share those emails with me, and we can discuss things further if anybody wishes.
Okay. Thank you so much, Dr. Collins. We really, really appreciate it. If anybody has any questions, you can submit them in the chat. And I'm going to start sharing my screen again and introduce Chanel Johnson from Pfizer. She's going to be sharing a disparities update for us about prostate cancer disparities in the United States. So Chanel, I'm going to stop sharing and let you share. Thank you so much again, Dr. Collins. And I'm going to mute myself. Chanel, whenever you're ready, you can take over.
Okay. Wonderful. Can you see my screen?
Yes, we can.
Okay, wonderful. So everyone, to introduce myself, I'm Chanel Johnson, and I am a key account manager for Pfizer. And our key account management team, what we do is we look at opportunities to improve the quality of care and the patient journey in areas where we have therapeutic interventions. And one place where our company has made a lot of investment is in the area of prostate cancer. And one thing that we have found and done some seeking to do a great deal of education on is around prostate cancer and the health disparities that impact African American men. And so this presentation will focus on 4 things. prostate cancer in African American men, clinical management, socioeconomic barriers, and then some areas and options to address those health disparities. And so prostate cancer in the African American men, and one thing that I would like to point out is that the COVID-19 crisis has really brought a lot of focus on health equity and health disparities. And it's bringing to light some great opportunities where patients are engaged and also health systems are very engaged on where are some areas where we can really work to reduce these disparities. And prostate cancer is a place where we have work to do. So as was mentioned earlier, there are many potential risk factors for prostate cancer, and the one we'll focus on is race and ethnicity. And with prostate cancer in African American men, as you can see, I know when we look at these charts, you see different rates of cancer affect different races. And with African American men, prostate cancer is by far and away the highest incident. And according to lifetime estimates, about 1 in 7 African American men will develop prostate cancer in their lifetime. So the African American men that you're treating will more than likely have known someone very personally who has been impacted by prostate cancer. And in addition to the incidence being higher, as we can see with this graph, the incidence rate of prostate cancer is 60% higher in African American men than white men. But a place where there really is an opportunity to make real change is that with African American men, they're more than twice as likely to die from prostate cancer as white men. And we see these disparities acutely in Arkansas as well. And so some possible causes of cancer health disparities, they look at 2 different things. Perhaps it's clinical factors. So earlier transformation from latent to aggressive prostate cancer or prostate cancer, which grows more rapidly, and then lower treatment rates. And then there are areas where it's potentially socioeconomic factors. So lower socioeconomic status, unequal access to care or uninsured, and then also behavioral perceptions about health care. So those are things that, that also must be considered. And when we look at clinical management, one area is where we don't see there's a big disparity in races outside of the white race being involved in enrolled in genomic sequencing research. And so it's really important, especially for prostate cancer, when we see so many Black men that are being diagnosed. There would be there's really a need for greater samples to detect where there may be some mutations that would need to be addressed. So the low enrollment of minority patients in cancer sequencing, it limits the ability to detect targetable mutations to specific minority groups. And we see this in clinical trials in general as well. And so, as Dr. Collins had mentioned, with prostate cancer screening considerations, it's important, it's reasonable, according to NCCN guidelines, for African American men to undergo earlier and more frequent screening. I know that prior to working in this space, I did not realize that for Black men, it's considered appropriate to begin that process of screening at age 40. And as Dr. Collins mentioned, that baseline is very important because lower PSA threshold levels in African American men may be more predictive of future risk of prostate cancer. So seeing that difference can help to identify the risk level for a Black man. And as we can see, the optimal PSA threshold level for Black men, 1.9, and for white men is 2.5. So with prostate cancer screening and incidence, we do see that there have been numerous changes over the years where it's made prostate cancer screening a bit confusing. We know that there was the approval of the PSA test to monitor prostate cancer in 1986. In the early 90s, we really reached the peak of prostate cancer diagnosis, and the FDA approval of the PSA test really did a lot to test asymptomatic men for prostate cancer. However, we've seen the screening rates gradually decline. And this just shows a bit more about the incidence rates by year and by race. And as we can see, the incidence rates, we saw it very high in the mid-90s. So that's reflective of the level of screening that was being done. So it remains to be seen what we will see in the future, considering that the USPSTF guidance has changed in regards to when patients should be screened. And so in 2008 and prior, we know that there were some changes around no screening for men aged greater than 75 years, no screening for any men, everything being done in regards to shared decision making. But as far as it goes for the Black patient, many of our NCCN, as was mentioned before, are making recommendations individually, and for the Black man, as we mentioned before, age 40 is appropriate to start that screening. And then another area for in regards to clinical treatment is that African American men with prostate cancer may be less likely to undergo treatment. And so when we look at the different areas of treatment, we see that Black men are in virtually every single category are receiving less treatment, less therapy compared to white men. So there's an opportunity to ensure that that Black men have the same standard of care. And then also it states here that African American patients may be more likely to receive androgen deprivation therapy than radical prostatectomy for low risk disease. And that's important to note that ADT is not recommended by NCCN as an initial therapy for low risk disease. So it's also important that in addition to receiving the same standard of care, also that clinical guidelines are followed in order to ensure that outcomes are as great as they can possibly be. And then, as I mentioned before, in regards to genomic sequencing, minority enrollment is also low in phase 3 metastatic prostate cancer clinical trials. So as we can see with Black patients, Hispanic, Latino patients, Asian American patients, we see that these patients are, these races are not well represented in clinical trial enrollment. And it's really critical that we have greater diversity in these phase 3 trials, because that's really the key driver of prostate cancer mortality when we're looking at prostate cancer that has metastasized. And of note, 5-year survival is 31% in patients with metastatic prostate cancer, compared with 100% in patients with non-metastatic prostate cancer. So we really do have work to do to ensure that patients, Black patients, are comfortable enrolling in clinical trials, and also that it's being offered to them. And then another thing that is important for health systems and healthcare providers to consider is that African American men are at greater risk of loss to follow-up. So African American men undergoing active surveillance were lost to follow-up at a rate of 2.8 times greater than white men. So that loss to follow-up may put African American men at greater risk of missing the opportunity for treatment if their disease progresses. And so also when we're looking at socioeconomic barriers, being uninsured or privately insured, more likely to be diagnosed with advanced cancer and at higher risk of cancer death. Social and economic disparities and cultural differences affect access to high quality health care. And then also, we found that African American men in rural areas also have significantly higher prostate cancer mortality than African American men in urban communities. And we see this in Arkansas as well, significantly higher mortality rates for Black men in the Delta, for instance, compared with in other parts of the state. And then also patient trust, behavior, and awareness is another issue. African American men with prostate cancer exhibit disparate outcomes for certain prostate cancer screening measures, and some potential reasons: lower physician trust scores than white patients, less likely than white patients to see the same provider at each medical encounter, and viewing prostate cancer and/or prostate cancer screening as a threat to manhood. And a series of non-focus group discussions found that Black women women of Black men wanted to become more educated about prostate cancer screening. And so we talked about some of the reasons. So where are there opportunities to address these health disparities? And so the Institute of Medicine had recommended a few options. One is strengthening the stability of provider-patient relationships, including guidelines for the stability of patients' assignment to primary care providers. As mentioned on a prior slide, Black men are less likely to see the same provider with consistency. So that's an opportunity for health systems and in order to make some purposeful interventions to ensure that patients have that consistency of care and are able to strengthen that relationship. Also promoting the use of evidence-based guidelines for consistent care, ensuring that patients are given the same standard of care regardless of race, in order to ensure that the best outcomes are received. Also implementing patient education programs to increase knowledge of access to care and shared decision-making. And then also providing financial incentives for practices that reduce barriers and encourage evidence-based practice. And EHR, integrated solutions, are a way where it can provide a gentle push in order to address healthcare disparities. And so they looked at a 5-year pragmatic study across 5 cancer systems, and there was an adoption of an EHR-based intervention. And I saw it in the news recently. We've seen incredible progress made in regards to the diagnosis disparities between Black patients and white patients in regards to lung cancer. So this is a great example because it's really led to real results. So some of these intervention components included a real-time warning system derived from EHR, race-specific feedback to clinical teams on treatment completion rates, and a dedicated nurse navigator. And the primary outcome of the trial was receipt of potentially curative treatment. And here they showed that pre-intervention, we saw where that disparity existed, 78% of white patients versus 69% of Black patients receiving that potentially curative treatment. And we saw afterwards that there was a significant increase. One, the disparity no longer existed, and also all patients were receiving better care. We see at that point 95% of white patients are now having the receipt of potentially curative treatment, and 97% of Black patients. And then also there are some other areas where EHR integrated solutions can help to provide some solutions. So one is having the EHR being programmed to deliver alerts triggered by the missed appointment, lack of follow-up within 30 days of initial visit, no definitive therapy scheduled within 90 days of initial visit, and no definitive therapy performed within 120 days of initial visit. So this helps to ensure that the patient remains engaged and is not lost to follow-up. And then also having navigators monitor the EHR registry on a daily basis. Warnings delivered to navigators' face page and require documented action to resolve. Navigators re-engage patients and identify barriers to care, and physician champions engage clinical team and discuss possible remedies. And then also it has here some of the identified barriers to care. Lack of transportation, difficult finances, mistrust, and miscommunication. So this engagement with the patient in order to identify where the barriers are helps to address some of those patient needs. A variety of financial support programs and initiatives do exist to assist patients. So oncology financial navigators can help patients to find resources to assist with covering out-of-pocket costs such as medications, copays, and insurance premiums, and then obtaining insurance and receive medical care that they otherwise would not have been able to afford. So we know that financial navigators that are engaged with these patients can often help to find grants or other areas of assistance in order to ensure patients can obtain that care that will give them the best outcomes. And then specialty pharmacies, where a number of these therapies are processed via specialty pharmacies, they may offer assistance as well in identifying financial support for patients. Then community initiatives can be effective in reaching African American men with health risk. I know the Arkansas Prostate Cancer Foundation is doing a lot of things to engage their patients and ensure that Black men as well as Black women are being engaged in order to reduce disparities. And so this is an example of an engagement project that work to try to engage the patients to a greater degree. And so what it did was really work to learn strategies that may improve the mental and emotional health and build social support networks with other men. So tapping into existing social networks, capitalizing on established relationships of trust, appeals to a broader movement for social change, and enlist past participants to become MOCA mentors. And as I mentioned before, with a national conversation that we're having now on disparities in race in a variety of areas, there is a greater engagement around what can we do to ensure that there's greater equity, and healthcare is particularly acute. And MOCA did have great success in engaging 4.2% of African American men in the community. And so a number of, and that was really incredible considering that there were in a city of 155,000, they had 245 men complete the program, 160 attend MOCA events, 107 took the MOCA pledge, and then 150 indicated interest in participation but had not yet engaged in any MOCA activities. And so in summary, we do know that the incidence of prostate cancer is 60% higher in African American men than in white men, and also the mortality rates are much higher as well. And evidence suggests that there are disparities in clinical trial participation as well as treatment. Socioeconomic status and geography, urban versus rural, can influence cancer risk and outcomes. And then financial navigation may enhance the patient experience. And engaging men at the community level may help in reducing disparities. That's all that I have, Kara. If anyone had any questions, I can answer. And if not, then as Dr. Collins mentioned, I can answer any questions that are sent to you at a later time.
Okay, thank you so much, Chanel. I will take back over the screen. Does anybody have any questions? Oops, sorry. Does anybody have any questions you can ask in chat? I just want to thank both of y'all for taking your time. Let me start my video, sorry. Can y'all see me? I just want to take the time to thank y'all for joining us and discussing today. Dr. Collins, and I saw Dr. Kilambi for a little bit, and Chanel, thank you so much, and Pfizer, thank you so much for everything that y'all have done to boot this off the ground. This is our first ever early detection guidelines and disparities update, and we're hoping to grow. We got to crawl before we can walk, and hopefully we're going to be running eventually. But I just wanted to thank everyone for attending, and if you have any questions, you can feel free to email me at clements@arprostatecancer.org or call our office at 501-379-8027. And again, thank you everyone for participating, and we hopefully will see you again in the future. Thank you, guys.
Thank you.
Okay, bye-bye.
Thank you.
Bye.